My name is Siddharth Singh. I'm an interventional echocardiographer and cardiac intensivist from Cedars-Sinai Medical Center in Los Angeles, California. I recently presented at the International Academy of Cardiology scientific sessions held in Boston. The title of my presentation was Current and Emerging Therapies for Tricuspid Regurgitation. Now, most adult human beings have mild or mild to moderate tricuspid regurgitation, the prevalence of which increases with age and is also higher in women. Moderate or severe tricuspid regurgitation affects nearly 2 million people in the United States. Over the last 2 decades or so, we have increasingly recognized the clinical impact of tricuspid regurgitation and how it affects clinical outcomes independent of left ventricular function, other valve disease, and pulmonary artery pressures. Interestingly, in the surgical literature, surgery for isolated tricuspid regurgitation carries the highest mortality of all valvular heart surgeries. Hence, percutaneous options for correcting tricuspid regurgitation are needed. When it comes to classifying tricuspid regurgitation, we classify it as primary, secondary, or having mixed etiology. Primary tricuspid regurgitation means that there is something intrinsically wrong with the valve leaflets, as would be seen in prolapse, endocarditis, or from pacemaker leads. Secondary tricuspid regurgitation, or what is commonly called functional tricuspid regurgitation, means that because of RV dilation or dysfunction, the tricuspid annulus is dilated and the valve leaflets are not able to coapt. As one would expect, common causes for this include cardiomyopathy, elevated filling pressures, and what we have increasingly learned over the last few years, atrial fibrillation. Now, when it comes to surgical options for tricuspid regurgitation, repair is favored over replacement. In terms of indications for primary TR, it is recommended that the valve be repaired if a patient has a significant regurgitation as is symptomatic. In asymptomatic patients with primary TR, one may still intervene if there is progressive RV enlargement or dysfunction, because we would like to avoid irreversible RV damage. For patients who are undergoing surgical repair for left-sided heart valve disease, it is also reasonable to operate on the tricuspid valve if there is significant regurgitation. Since TR or tricuspid regurgitation can look better under anesthesia on echo, it is recommended that in cases where there is even mild or moderate tricuspid regurgitation, surgeons repair the valve if there is tricuspid annular dilatation. It is widely believed that tricuspid regurgitation tends to improve once the left-sided valvular lesion is fixed. This is only true in very rare cases, and in most cases there is progressive RV enlargement and worsening regurgitation when patients are followed over time after left-sided valve surgery, and if the right side is left unfixed. So like I said, over the last couple of decades, the clinical importance of tricuspid regurgitation has been increasingly recognized, and the high-risk nature of tricuspid valve surgery in many patients has been noted. As of now, there is no FDA-approved therapy for tricuspid regurgitation. So over the last 5 years, there has been increasing research on development of percutaneous options for tricuspid regurgitation. Investigators have tried to mimic the surgical approaches for tricuspid regurg. Procedures have mainly entailed ensuring better leaflet coaptation. The most experience we have is with using the mitral clip in the tricuspid position, and over 600 cases have been done worldwide. Another device that has been looked at for ensuring coaptation of tricuspid leaflets is a spacer from Edwards Life Sciences that helps promote leaflet coaptation. Additional approaches have looked at percutaneously performed annuloplasties, as in mitral line and cardioband. In very advanced cases, investigators have also implanted percutaneous balloon expandable or self-expandable valves in the inferior and the superior vena cava to prevent backflow of regurgitation and reduce congestive symptoms. Given the large size of the tricuspid annulus and the fact that it's usually not calcified, implanting percutaneous valves in the tricuspid annulus is a challenge. However, there are devices currently being developed and looked at in compassionate use studies. So especially given that there is no FDA-approved percutaneous option for this very sick population, ongoing research efforts are very important. I should also mention that for these percutaneous trials going forward, we have learned that patient selection is very important, and it is very important to also identify patients who will not benefit from the interventions proposed.